So first thing, I don't normally dress to color coordinate with the presentation. That was purely an accident today. Sorry about that. Secondarily, I currently am the managing director of the risk management services here at the Stanford Enterprise. We'll talk a little bit about what that risk management function looks like, so I'll get into that detail a little later. But I've been here about, I think it's going on 5 years actually, and prior to here I was a corporate director of risk management for what's now Dignity Health System, and then spent about 16 years as an administrator and risk manager with the University of California Medical Center system, so both up at UC and down in Irvine. So by educational background, I have a master's in healthcare administration from George Washington University, and somewhere way a long time ago when I started my administrative career, I got the harebrained idea that I should go to law school so I could better understand healthcare management, which was a sad commentary, and so ultimately got a law degree along the way, and for the past 20 some odd years have combined the operational experience with the legal, and whatever mechanism works best, and risk management seems to be that mechanism. So without further ado, because I'm either between you and dinner or other more fun activities, let me go ahead and get started. So you see up here it says the Risk Authority, and you're probably thinking, what the heck is that? How come it doesn't say Stanford? How come it doesn't say Packard? It did up until about 2 months ago. Without getting super complicated, we are the risk management unit for the Stanford Enterprise, the Packard Enterprise, all the clinics, all the physicians, and now the medical network, which includes the PCHA and UHA physician-related practices. In order to sort of neutralize ourselves and be the appearance a little bit more of Switzerland, in that we deal with everybody, not just Packard, not just Stanford, not just PCHA or UHA, we went through a major corporate reorganization, formed this new corporation called the Risk Authority, which is actually an owned enterprise of the Stanford organization, and we are employees technically of the Stanford Enterprise and do our work on behalf of the organization. 2-3 months ago, you would have seen the Stanford University Medical Center Network Risk Management. So a little bit about why the little difference there. So I'm going to really quickly go through, because we've learned over the course of time that dealing with all of you sometimes creates a little bit of confusion about what risk management is, what we're in place to do, how we work together, and generally some of the operating principles. So I kind of termed this the 5 whys, the who, what, where, when, why of risk management, and we're going to run through it in that mode. So basically, what is risk management in the first place? If you had told me at a ripe old age of 5 that a risk management career would have been a good thing to pursue, probably would have looked at you cross-eyed, and even in my later years, I had trouble explaining to family and friends what exactly I did. Risk management is really an insurance function. So we are sort of like the insurance company for the organization. If you didn't practice in a protected environment like an academic medical center, and you were in private practice or in other group settings, you would likely go out and purchase professional liability insurance coverage, because it's part and parcel of practicing as a physician. We're the insurance company for the organization, and we actually have 3 captives, which is a form of insurance arrangement that handles all the professional and general liability, and now the construction liability for the Stanford University Medical Center, the School of Medicine, and all the hospitals and clinics. So risk management is really an insurance concept and an insurance function that basically encompasses lots of ways to manage the risk of whatever business you're insuring. We provide consultation and resources to anybody who's affiliated with the university or the School of Medicine or the hospitals and clinics. You technically are our insureds, so we're available to you for whatever consultation or resource you may need related to your insurance needs. We also have our own, because we're self-insured and manage our captive, we have our own claims and litigation unit. So for example, everybody here has car insurance. You pay an insurance company to have car insurance. When you have a smack, you call your insurance company. They have a claims adjuster. They have people that if it gets gnarly, who will help you defend and mitigate whatever happens. And along the way, you get little perks for good risk management with your insurance company. For example, if you never have speeding tickets, you might get a break on your insurance pricing. If you wear your seatbelt, if you can demonstrate your car is well garaged, if you live in the right zip code. All of that are risk management methods to help reduce the cost of the insurance program. We have our own claims and litigation team as well. There's a unit within my department that specifically is in place to manage the claims and the litigation that crop up in relation to the patient care activities. And as I said, the construction and others. We provide education and support. We do a bunch of education, both internal to the organization and nationally and internationally. We're working on some projects in the UK right now, kind of transforming, helping them transform their current health system and developing risk management strategies along the way. And then, and here's the tricky part, we coordinate with other key areas, but we aren't all that. So oftentimes people call our office and they say, I was told to contact legal. Okay, let me be really clear, we're not legal. I was told to contact compliance. We're not compliance, but that doesn't matter. If you get to us, either we're gonna deal with you or we're gonna help coordinate with all the other colleagues here who are in place as a support and a resource. For example, compliance and privacy. When would you likely call them? Lost your computer, had a problem with a patient who's taking pictures with their cell phone of your patient care activities, anything that relates to privacy or the elements of compliance, billing. They've taught you, I'm sure, how to document to keep within compliance. We coordinate with our colleagues in quality and patient safety. Again, those are operational departments within the medical center and clinic environment who are doing great things and handling a multitude of things that we're a party to as colleagues, but we don't operationally handle. For example, peer review. All handled usually out of the quality department. We might participate as members of a committee, but not our gig. There are other people well suited to handle those activities. Along other areas which we work in coordination with the Office of General Counsel. What you may or may not know is the university has its own Office of General Counsel, which you can think of as the university's law firm. Those individuals who work within that environment are the only ones technically in-house who are authorized to practice law on behalf of the university, the medical center, hospitals, and clinics. We do a tremendous amount of work in coordination with them. They technically oversee our claims and litigation process, but they are the go-tos for a variety of things. If you were calling them, you could say, I'm calling legal. Calling us, you're calling risk management. Guest services and patient relations. Both organizations have very good services around this. They're the individuals who are patient-facing with patients who have concerns, complaints, need assistance with navigating their healthcare system. We are not forward-facing. We're a little bit more behind the scenes. in place to help the staff and serve as a resource, not to be upfront with patients, because who are we to them? Just some anonymous group out of nowhere. We work closely with leadership and the medical staff and clinic and hospital administration. We do a ton of work in conjunction consulting with various and sundry leaders, and again sit on many committees to provide a risk management perspective. We also have a whole group of outside counsel, law firms throughout the Bay Area with whom we work closely with when we outsource some of our claims and litigation handling. But again, we maintain the control for that. So some of you may have had contact with some of the attorneys who work on our behalf, who introduce themselves as working on our behalf. That would be the retained counsel. And then others is indicated. So again, we're not everything to everybody, but we certainly coordinate with everybody who's in place to do whatever needs to happen. So who are we? We're 25 staff members within the risk management division. We think we're pretty darn lucky. We're really well resourced. We're also incredibly, and I'm bragging a little bit, well-trained and have tons of experience. We have 2 physicians on staff, both of whom at some point changed their practice of medicine to focus on law. Both went to law school, got law degrees. One is an OB by training, one's an internist. So you may have involvement with them. We have several individuals with clinical backgrounds. We have individuals who are experts in insurance and risk financing. Believe me, it's an actual discipline. Law, although we don't require a legal background, most of us have law degrees or have practiced law. We also have a unit that focuses on strategic decision analytics, where we do some analysis around strategic decisions to evaluate upside of risk. For example, when we're looking at working with individuals here who are thinking of launching new programs, we work with them on developing the return on investment analysis to see what risk factors it would mitigate and how that would pan out. We also handle a portion of the work comp in our office, so there's a whole division that deals with that. I mentioned construction risk, so all the deep holes and the cranes and everything out there, we're actually insuring all those activities and therefore have a direct responsibility for the safety and overall progress of the construction. And then I mentioned claims management and our enterprise risk management, so we work closely with compliance on that. Where are we? We are on Page Mill Road, so a lot of times we get calls and people say, can you come down here? And I'm like, no, we're over there, but between that short distance and the construction, it can be a half-hour exercise to just come and go. So more and more we're working remotely. Doesn't seem to impact anything. We're frequently on campus, but we live over on Page Mill. Our office hours are Monday through Friday, 8 to 5. Feel free if you're ever over there. We're actually right near the home pharmacy, the Packard Home Pharmacy. I think we're moving over to finance. We have a 24/7 capability to handle any risk management need. So if middle of the night, weekends, early in the mornings, you have a risk management question or issue, contact the page operator, ask to speak to the risk manager on call, you'll get somebody like that. And then our main office number. Why would you call us? Just because, like, you think it's fun? No, no. Most of the time, we are involved with helping the physicians and staff manage an adverse event. What about that is our involvement? Really, again, providing the consultation and resource to the frontline caregivers and those who are dealing with the patients and the families in response to something that went not as planned. And so the long story short on that is, if you truly have had an adverse event or been involved with an adverse event, We certainly want to be involved. We'll talk a little bit about the steps that go with that, but know that we're a resource to you specifically in advising and consulting on that. If you get a subpoena or a letter regarding direct patient care, and I qualify that because over the course of your careers, you will get letters from attorneys about patients who've been in auto accidents or custody battles or lots and lots of things. Now, generally, we don't handle those matters, but if you get a letter from an attorney, it can somewhat be a little bit intimidating or unclear to you exactly what's going on, and so we say, call us. Let's talk about it. We'll be happy to advise you on the handling of it. Don't worry about the fact that you've gotten that letter. We'll walk you through the steps. We often get calls from residents in particular who may have been, who received a subpoena about a patient care matter, and the first thing they say is, I barely knew this patient. I was, a third-year resident. I saw them one time, and they're panicked and they're concerned appropriately, and they want to know what's going to happen. We will walk you through how that's going to happen, what's going to happen, and we will be the ones who ultimately take that subpoena off your hands and deal with the attorneys on those matters. If you receive a California Medical Board letter where either they're concerned about your care and treatment or have questions about your care and treatment and the focus seems to be the care and treatment you were involved in, let us know. We actually have a whole outside firm that helps us mitigate the handling of California Med Board letters. If you need insurance certificates or verification of your coverage, as you move along in your career, and perhaps you don't stay at Packard, wherever you go next is going to want to know who was your insurance carrier and what was your coverage, and do you have evidence of that? You would call risk management. We have a whole unit that does nothing but spit out certificates of insurance and fill out credentialing letters about insurance coverage you may have had while you were here. Again, consultation and advice. We are in position to answer any question or to appropriately triage you to any of our colleagues who may be in a better position to help, and then we do general information and education. We also have a couple little things about what happens when you call us. The natural inclination is for, especially when it's involving patient care circumstances, for providers or staff to want to document in the medical record that they've talked to risk management and risk management said. And you'll hear us often say, don't do that. Not appropriate to document that discussion in the medical record. It has nothing to do with patient care. It has everything to do with us talking you through that patient care circumstance. Oftentimes, though, people will come back and say, well, I was trying to cover my bases because I'm afraid whatever I did in response to our discussion will get me in trouble and I want to share the wealth. Again, not appropriate. You wouldn't document in your medical record that you talked to your insurance company and they told you to do X, Y, and Z. No, the medical record is for your clinical judgment, decision-making, communication about care. You have other places you can document discussions with us. For example, Quantros reports, or on the Stanford side, a SAFE report. If there's an untoward medical event, that's the appropriate place to put your documentation about what you thought, what happened, our discussion. And oftentimes we get questions about, can I keep notes about it, my own notes, private notes. Technically no prohibition against that. Cautionary note, please keep those protected and safe so that they're not easily located. They're confidential information no matter what. You can do that if it helps you to maintain your thought process on something that may not become an issue till a year down the road, but believe me, if you've talked to us, we've made notes, we have a record, we'll follow up and go from there. Some basic guidance on when there's an adverse event. I mentioned that that would likely be the most prominent point at which you would call us, other than you need insurance verification. And we have found over the course of time that it can be very challenging to manage an event that's unanticipated, and in fact where there may or may not have been patient harm. We're going to always tell you, manage the clinical situation first. We're sort of ancillary to everything. It's not about covering your bases. It's not about getting things legally handled. It's about keeping your compass focused on the patient and managing appropriately with the care team whatever mitigation strategies there are for making sure that patient remains safe and on the right clinical course. We're not your first call. There are times I could tell you stories where you can actually hear the chaos in the background when somebody calls us and they're talking to us and we're like, what's going on with the patient? What's going on with the patient? Hang up, focus on that, call somebody for help. We're not gonna be in a position to help you manage that clinically. And it's not important you talk to us at that moment. You should also know that oftentimes you can get the answers you need by talking to your peers or your attendings, or attendings talking to other attendings, that really risk management is not who's directing the activities here. You have processes and policies and procedures and standard of care that are much better vetted with appropriate medical advice. So we don't want to be your first call. We're happy to talk to you, but after you've sorted things out. We're in the healthcare business, folks, not the legal business. So every time we get a call where somebody says, well, what's the legal implication of this in relation to my patient? We say, forget about the legal implication. Really? This is about managing medicine and your patient care. If you do that appropriately, there's not even going to be a legal issue. So don't worry about what drives things legally. We're in the healthcare business, and that's what your focus should be. Know that there are general policies and principles. We don't get annoyed. Okay, maybe sometimes when we get asked questions that are easily within the accessibility of others. For example, both organizations have a lot of policies. They're available on the intranet. If you want to know about how to manage a disruptive patient, there's a policy. If you want to know about consent, there are policies to guide you through that. Again, we'll be happy to talk you through that, but we oftentimes think if people just step back, looked at what other resources are readily available, it would save the angst of, quick call to risk management. Minimize the swirl. There are so many circumstances, particularly in the pediatric environment, where there's family swirl, there's staff swirl, there's all this distraction going on, and we often get called and we'll be like, forget about that. Not that that's not important, but if we're doing what we need to do in relation to the patient, communicating appropriately, managing the medical care, everything else is sort of ancillary. And I'll tell you one really quick example. It seems as though we do have several circumstances where there's disruptive parental relationships. Mom and dad are either in a contested divorce situation or are divorced and somebody's got another new spouse. There can be so much swirl around, can stepmom have information, what's going on, mom doesn't want dad coming here, blah, blah, blah. A bucket of stuff that will bog you down and twist you up with a lot of time and energy that in the long run doesn't benefit anybody. You can't be the arbiter for some of our family dynamics. So again, we often help talk both you, social work, anybody we work with on these matters to really, again, put the focus on the patient, set appropriate boundaries with the parents, make them work it out, and leave us out of that role. And then lastly, get the benefit of your really great efforts. When you have discussions with parents or patients about educational aspects of their medical care, or things are rocky and you're spending a lot of time being extra helpful in explaining or getting information appropriately to the right folks, get the benefit of that time and that effort by letting that be known in the medical record. No magic to, but if you spent 20 minutes explaining why this child can't go home today, instead of being annoyed after fighting with the parent about that disagreement, get the benefit of what you talked about and the advice and the warnings and the education around the difference of opinion you and the parent may have. Following an event, and again, that's the most critical time that you're likely to be in contact with risk management, and let me just be really clear on this point. We have heard over the course of time from residents, from fellows, from physicians, attending physicians, they didn't call risk management because they thought we were on the stop only in place to help the hospital. Not true. We are risk management for all purposes. We take no sides. We, again, try to manage the situation from an insurance and risk perspective. We don't pit you against the hospital or the staff against the physicians. That's not how it rolls. We're equal opportunity risk managers. So again, following an adverse event, it's not about sort of the debate with other staff about that. It's about managing the clinical situation, notifying and informing those who should be in the loop to know, for example, attendings or others who need to know what went on with the patient. We're in that loop eventually, but again, down the road. And then disclosure, what we call a apology or communication about a particular event. We are more than happy to work with you on how to finesse those conversations or how to have them if they're not intuitively comfortable. There are some physicians and others who are really skilled at those discussions, but they don't come easily. And again, we're always in place to help sort of manage how to go about those discussions. There is a policy at Packard and also within, I believe, the medical staff rules and regs or bylaws about the culture and the position that this organization has taken about being forthright and transparent in disclosing mistakes and adverse events. And we really do support and believe in that, so we'll help you navigate through that. Documentation about an adverse event again, shouldn't be fraught with blame game, trying to figure out what happened when you don't know. It should be about clinically the factual circumstances and what we're doing in response to those. Remain available. We know patients and families have a tremendous amount of at ease when they know that their providers are available to them and willing to explain. And it isn't impossible for us to actually rebuild trust after something's happened through simply being available and communicating. And then there can be some rough days or rough moments after an event if you've been directly involved. We have a really strong position on this. We're going to be working with the School of Medicine on developing support networks for practitioners who have been involved in adverse events, because you know what? It feels crappy, and everybody knows that, and we really want to support not only the patients and the families surrounding these circumstances, but those involved from a clinical perspective as well. So we're working really hard to develop some programs that will be first-line support for residents, fellows, and others involved in critical events. And then lastly, we have something you may or may not have heard about called the PEARL process. And PEARL stands for Process for Early Assessment and Resolution of Loss. And it's, we're one of maybe, I want to say now 6 medical centers around the country that were sort of out of the gate first in developing a culture where if we knew something went wrong because of something we did or didn't do, we wanted to be able to reach out to family and patients, to be able to deal with them at the time when they most need our help and support and assistance, financial or otherwise. And so we developed a PEARL process, which in our neck of the woods requires us to early on and very quickly, in a very short period of time of a week to 10 days, to try to figure out exactly what happened, who was involved, and then to address immediate things that we can do to help resolve the family's angst over that issue. We have actually on